Good evening, doctors. Warm welcome webinar sponsored by Panacea Biotech. I am Dr. Agade, Head Medical Affairs from Mumbai. Thanks to all of you for participating in this webinar. Today's webinar we are having on approach to bleeding disorders. For this, we have invited distinguished speaker Dr. R.M. Subbaiah, who has completed his graduation in medicine from Madurai Medical College and subsequently completed his MD medicine from prestigious institute in India, PGI Chandigarh, and a DM from CMC Vellore. He is a hematologist and BMT physician, and at present consultant hematologist and hemato-oncologist and bone marrow transplant physician at Kaveri Hospital, Trichy, Tamil Nadu. He will enlighten us on the various bleeding disorders, its causes, the bleeding in all age group patients, the high risk patients, also the infectious diseases or the fever like dengue. Then what are the underlying causes and complications and how to diagnose in our routine practice based on the routine blood investigations? What are the special blood investigations are required? So it will be really very useful. The bleeding disorders or the hematological disorders are important and needs to get diagnosed in the beginning in OPD practice. Panacea Biotech is in association with the hemato-oncologist. We are with the launch of the dasatinib, our close association, the hemato-oncologist cases, and during this COVID lockdown period, Panacea Biotech has extended the academic platform since the lockdown across the specialty. Panacea Biotech is a pioneer into the generic. One of the global first generic is nab-paclitaxel, Pacliol as a brand name. And we are here with giving the quality medicines in the oncology portfolio. Hence, I am inviting here Dr. R.M. Subbaiah to enlighten us on approach to bleeding disorders. Dr. Subbaiah, please.
Thank you, sir, for the kind introduction. Am I audible, sir?
Yes, you are clearly audible.
Okay. Okay. So, good evening, one and all. So, I'll discuss this topic in under three divisions. First, I'll start with basic physiology. How does the blood clot and the pathophysiological aspect? Then we'll move on to the common causes and how to approach, followed by the most common reason being thrombocytopenia and special scenarios. Okay. So to start, we have learned in physiology the main components of hemostasis. There is an interaction between the vascular wall and the protein. Okay. So whenever there's a vascular constriction, that is the vessel wall shrinks its diameter to reduce further blood loss, and followed by platelets come as a defense. They adhere to vessel wall and form to stop further. This platelet proteins follow a cascade from the clot is stabilized. So from the point of vascular injury, platelet plug formation, that is the stopping of bleeding, is primary hemostasis. Then from platelet plug formation to stable clot formation is the secondary hemostasis, and the cessation by later. So the initial theory put forth the theory where we have two arms, the extrinsic and the intrinsic pathway. Extrinsic pathway is activated by tissue injury where the tissue have been combined to form complex. The intrinsic pathway is by contact activation. It follows a series from activation, subsequently from 12, 11, 9, 8, culminating activating factor 10. So all this happens on these phase of platelets. So the phospholipid and calcium is from the. So once the DNA is complex is formed, that is an information, and thrombin is the most powerful protein in the entire coagulation system, and this converts insoluble fibrinogen into insoluble fibrin, and cells and white cells mesh and gives more structure to the clot. And this
Sorry
extrinsic
to
pathway,
interrupt, Dr. Subbaiah.
common prothrombin. Yes, madam.
So there is some connectivity issue, I guess. The voice is not clear. The voice is coming in, interrupted a bit.
The
Yeah, yeah.
Sir, you can, video your camera, you can keep mute and continue with that. We will see.
okay, sure. So in the laboratory, we see the intrinsic pathway with the common pathway as the APTT. Okay. So if this theory is so, there are certain questions unanswered. If factor 12 is essential for hemostasis, that is to start the intrinsic factor, why does if that is not there, the patients don't bleed? So something else is happening, that this theory is not fulfilling what we are thinking about. Similarly, if extrinsic pathway and intrinsic pathway are independent of each other, hemophiliac should not bleed. That is, the intrinsic pathway has 8 and 9. So if they are defective, the extrinsic pathway should be good enough to form a proper clot, and the patient should not bleed. So that is also not happening. So with 8 or 9 deficiency, the patients bleed. And moreover, usually the factor levels in the plasma correlates with the clinical activity, whether there is a chance of bleeding or not, depending on whatever the level is. But if you take factor 11, there is no correlation at all. 40% factor level might bleed and a 10% may not bleed. So there is no proper correlation. So these are the questions not be answered by the classical theory, what we see as intrinsic and extrinsic pathways culminating in the common pathway forming fibrin from fibrinogen. So henceforth, the newer model is the cell-based model, where we have three parts: the initiation, amplification, and propagation. What happens here whenever there is a tissue injury? You know that the factor 7A is the first thing to get activated when they combine with the tissue injured. When the subendothelial collagen is exposed, they form a small quantity of thrombin. Okay, so tissue factor with 7A, they go through the 10S complex like what I have here and form a picomolar quantity of thrombin. This thrombin in further amplifying the coagulation cascade, and it brings a huge thrombin burst, and the enormous amount of thrombin is formed further, and it propagates and propagates the clot formation. And finally, it helps in converting the fibrinogen to fibrin and thereby a clot. So here afterwards, most of the problems are all explained by cell-based model. Okay. So moving on to the primary hemostasis, that is, this is well explained by the mucocutaneous injury. So signs are the oral cavity, the nasal mucosa, cutaneous injuries and all. So this is primary hemostasis. Usually they are superficial. They are more to do with the platelet count. If the platelet counts are low or dysfunctional, this can happen. So what are the sites you look for when there is a mucocutaneous bleeding? Starting from head to foot: subconjunctival hemorrhage, epistaxis or oropharyngeal bleed, hemoptysis, hematemesis, hematuria, hematochezia, and menorrhagia. So secondary hemostasis is the part after platelet formation. So initial defect in platelet up to the platelet formation is with primary hemostasis. Secondary hemostasis is more to do with the coagulation proteins. There you get a deeper musculoskeletal bleed like a muscular hematoma or a deeper soft tissue bleed. And hemarthrosis also comes under secondary hemostasis. Knowing primary and secondary hemostasis, another important thing is to know about important visceral organ or the critical organ bleed, that is like an intracranial bleed, which is a catastrophic, and it also depends on the location. A simple bleed may be life-threatening, like in that of the brainstem. And few things you got to remember are petechiae, purpura, and ecchymosis. Usually platelet counts or dysfunction abnormality will present as petechiae or purpura, but it's not hard and fast rule. Multiple purpurae petechiae may coalesce to form a larger patch like ecchymosis. Secondary hemorrhages usually present as ecchymosis. So up to 2 millimeters petechiae, maybe up to 3 millimeters to 1 centimeter is purpurae, and more than 1 centimeter is ecchymosis. These are the two terminals which we should keep in our mind. Apart from that, you should remember the common bleeding causes whenever you evaluate a bleeding disorder in a patient. Acquired is always more common in our clinical practice. Inherited are less common, but classical examples of inherited being hemophilias A, B, and C. A for factor 8, B for factor 9, and C for factor 11. Von Willebrand's disease, this is the most common inherited bleeding abnormality in the world. Okay, and platelet function abnormalities like Glanzmann's thrombocythemia or Bernard-Solier syndrome, and other factor tissues which will be rare bleeding disorders. And the platelets and coagulation factors may be normal, but you might have some problems with the vascular connectivity to tissue disease disorders like Osler-Wendover syndrome or telangiectasias. Acquired more common in our practice with drug-induced or infection-associated thrombocytopenia, liver disease, acquired autoantibodies, disseminated intravascular coagulation as an obstetric hemorrhage, on trauma. So when you approach a bleeding disorder patient, what are the broader questions? The idea is to differentiate whether this bleeding is due to an inherited cause or an acquired cause. So that has an enormous impact on your management. So what are the important questions you should ask is, is the patient or his or her blood relative ever needed medical attention from a bleeding problem? Or have they been told that they have a bleeding problem when they have been evaluated earlier? That's one important thing. And whether they have any disorder of the other organs like liver or kidney, and are they on any meds like antiplatelets or anticoagulation, which might help you to think about drug-induced causes. And any trivial wound should not bleed for a long time if they last for more than 15 minutes, or if they recur very frequently within the last 7 days of injury. Any spontaneous nosebleed lasting for more than 10 minutes or that required medical attention, that is epistaxis for more than 10 minutes despite compression, or a bruit with minimal or no apparent trauma at all, very minimal with disproportionate bleeding to the stimulus, and whenever there is any deep or soft tissue bleed. And in the female, heavy or prolonged or recurrent bleeding after menstruation or any surgical procedures, and bleed that has not been explained by the anatomic pathology. A simple colonic polyp, like a benign polyp, shouldn't bleed much if there is no ulcer, and in endoscopy does not show any significant bleeding focus. But if the patient is having significant anemia, then also you think about whether it could be an inherited abnormality or not. And how do you label as heavy menstrual bleeding? Either by a pictogram where you can say the clot is more than 1 inch diameter approximately, or a change in the pad or tampon more than an hour, resulting in anemia or low iron. And you think about inherited or a bleeding disorder in the patient when you have an unusual site of bleed like umbilical cord stump bleeding, IM site hematoma when the child is vaccinated, or if there's a joint swelling after a trivial trauma, or any intracranial bleed other than a massive RTA, then you I would think also consider this as one possibility. And any anemia that requires a transfusion, especially when the patient is having bleeding or requiring suturing to stop the bleeding, but also you should think about a probability of a bleeding disorder as a cause. And to summarize the history, concentrate more on the age of onset. Younger the patient, higher the chance it could be an inherited disorder rather than an acquired disorder. Spontaneous could be more of an inherited disorder than a trauma related. Unusual sites, think about inherited bleeding disorder. And more frequent and long lasting bleeding, think about inherited disorders. If there is therapy received like antiplatelet or anticoagulation, think about acquired. And if the patient requires transfusion therapy, suturing, then you think about a bleeding disorder in the patient. And whether the patient has responded to the therapy or not, that also might give you some clues to what is the diagnosis. But fine, despite all these questions, and the physician has to be convinced that there is excessive bleeding. Sometimes, especially in the pediatric patients, the mother might report a simple epistaxis which happens during a common clot as massive bleeding. So you should be intelligent enough to pick up whether that history is significant or not. And moving on to the laboratory side, what are the initial tests of hemostasis? This is as per the American Society of Hematology, where they say complete blood count with prothrombin time, APTT, and a fibrinogen. These four important things. Bleeding time is no more than initial screening test, okay, because it is very cumbersome. I'll come to that later. So CBC, PT, APTT, and fibrinogen are the four tests which are done as an initial hemostatic tests. And above all, bleeding history is the most important determining factor. Complete blood count, these are the parameters you know of. Hemoglobin total and differential counts, platelet count, and the red cell indices will give you a clue whether there is a chronic anemia like iron deficiency or an acute blood loss or hemolysis, which can be picked up from the indices. And also peripheral smear examination should not be missed, which can give you a lot of clues on the etiology why there has been abnormality in the blood counts. And the coagulation test being PT and APTT. PT is for the extrinsic and the common pathway. APTT is for the intrinsic and common pathway. What happens in PT? Whenever there is a tissue injury, we see the FACT7 is activated. So here, this shade is for your PT. So 7, activated 7, culminating in 10, and the 10S complex converting prothrombin to thrombin, and thrombin converting fibrinogen to fibrin clot. So in the laboratory side, what you do, you just add thromboplastin to the platelet poor plasma. So when the sample is sent in a PT-APTT tube, that is a citrated plasma, after centrifuging, you do a hard spin so that the platelets also settle down with the red cells. You have a plasma which is very poor in platelets. So for a coagulation test, platelets should not interfere in your plasma. If you want to do a platelet function test, then the plasma should have more amount of platelets. Then you do a soft centrifuge. Here you have to do a hard centrifuge, that is a hard spin to settle the platelets, and you just need the plasma alone. Onto the plasma on a 37-degree water bath, you add calcium, thromboplastin, start the stopwatch, and then just see when the clot is forming. So that is PT. It's very simple. Plasma, thromboplastin with calcium, and the time taken to formation of the clot is PT. APTT is in the same plasma, calcium is there, but you need to add a contact activating factor like kaolin or phospholipid to initiate the intrinsic pathway. From there, then the intrinsic pathway sets in and a clot forms. Here, you initially add a contacting factor to the plasma and you incubate for some time. Then the calcium is added, and finally you wait for the time taken for the clot to form in the lab. So, but these tests are all automated now. So you have to just separate the plasma and put it into the machine. The automated coagulometer will give you the time taken for formation of the clot as PT and APTT. And the reference lab, reference levels depends on what reagents you use, how do you do it in your lab. And whenever the PT or APTT is prolonged, the next thing is to know whether the prolongation is due to an inhibitor or a factor deficiency. So that is the concept of a simple mixing study. So in mixing study, what you do, you take the patient sample, the plasma from the patient, and you add a normal pool plasma. Okay, that is normal individual, multiple normal donors. You pool all their plasma and you aliquot, and you take an equal volume of both the plasma and you add it together, the mixture. Then now you repeat the PT or APTT on the mixture. So suppose if there is a deficiency here in the patient, you imagine this is a hemophiliac patient, is not having factor 8, suppose, and when you add normal plasma, 8 is added, 8 is there in this plasma. So when you mix, now 8 is replenished. So this plasma is supposed to give you a normal APTT. And if it does so, it's correcting. When you add a normal plasma, you think about deficiency. The deficient factor is replenished from the normal plasma, and you get a normal APTT. If that is not happening, you think about an inhibitor. Despite adding all the factors, still the plasma is not clotting appropriately in the whatever time it has to do so. So then you think about there is some inhibitor which is hampering your clot formation. So, and the same thing, the inhibitor can sometimes be time dependent or time independent inhibitors. Depending on those, we have varied etiologies. So I'm just explaining the mixing study again. The patients and normal plasma or mixed equimolar equal volumes, and then you wait for half an hour to 2 hours, and you repeat the test and see. And the time dependent on time independent will depend upon how the incubation is there. Similarly, you incubate an already mixed sample also, and you can incubate for 2 hours, then you can mix also. So if you mix it immediately and then see whatever APTT you're getting, is it different from separately incubating for some time and then repeating the test. So certain factors, certain diagnoses have a time dependent mechanism. That is, initially there is no inhibition, later it happens. But the lupus anticoagulant and all is not time dependent. So we not go into those details. All you have to remember is you need a mixing study to differentiate it's a deficiency or it's a clotting factor inhibitor. In inhibitor, there are some time dependent inhibitors, time independent inhibitors are there. So the same thing is put up here. And when you do a mixing study, if you normalizes, you think about all the intrinsic factor deficiencies like 8, 9, 11, and 12. And if it initially shortens and then prolongs, this is time independent inhibitor. Whether you incubate initially or you mix and incubate, whatever it is, APT is still prolonged, we think about lupus. Okay, if it shortens initially, that is after you mix, it corrects initially, then it gets prolonged again, then you think about a factor 8 or 9 inhibitor. So that is time dependent inhibitor. So time independent is lupus, time dependent is factor 8 inhibitor. Okay, the next test is the, after finishing PT, APT in a mixing study, you need to know about what is the bleeding time. And now we do by a modified IV method, you need a sphygmomanometer to occlude the superficial venous system, a standard lancet, which gives you a cut injury into your skin of specified measurement with 3 millimeters deep and 3 millimeters of width. And you need filter paper to blot them and a stopwatch. After this, most of you would have done this in your physiology, but remember this is not an easy test to do. So that's why bleeding time is not a part of initial hemostatic screen. If there are 10 technicians in your lab and everybody does it, there will be a lot of difference in the values what they get. And very experienced technicians are needed to do this test properly. Okay, and normal bleeding time is 2 to 8 minutes. So you're going to occlude the superficial venous system. A standard puncture is made with the lancet. Then you're going to blot, start the stopwatch until it stops oozing out. And that is the time taken. That is the primary hemostatic time. That's bleeding time is 2 to 8 minutes normally. You think about platelet dysfunction whenever it's prolonged. And never do this test when there is thrombocytopenia. It will be obviously it will be prolonged. So less than 50,000 platelet count, usually this test should not be done. And in children less than 3 years also we don't do because they won't cooperate. So that's why it's not done in children. This is just to show you that after occluding the superficial system, 2 standard punches are made. You keep on blotting after starting a stopwatch. When it stops, you check for the time to decide how much is the bleeding time. So this table just shows you simply you can think about what are the possible different bleeding disorders by these simple tests. The bleeding time, platelet count, PT and APGT. For a normal individual, all will be normal. If you have a low platelet count, but your bleeding time is normal and PT-AP is also normal, this is that isolated thrombocytopenia. The first thing you'll have to rule out is a pseudothrombocytopenia, and patient may not be bleeding at all. Platelet counts may be more than 50,000. You think about all the possible causes for isolated thrombocytopenia. And if you have a prolonged PT, others all being normal. A normal APTT, a normal platelet count, isolated PT prolongation is usually a factor 7 deficiency or an early liver disease, because factor 7 has the shortest half-life. So when it is lost, PT prolongs initially in a liver disease. In the other way around, if you have an isolated APTT prolongation where your PT, platelet, and bleeding times are normal, then you think about the deficiency of those factors which I have listed in the previous slide: factor 8, 9, 11, and 12. And lupus anticoagulant also can produce this picture, but it will be an inhibitor there. When you have both PT and APTT prolonged, you think about common pathway abnormalities like factor 10, 5, 2, or fibrinogen deficiency. Okay, or a full-blown liver disease also can have this picture, or warfarin overdose also happens when it produces the same picture. If your bleeding time is prolonged, your platelet count is low, both your PT and APTT are prolonged, then think about a disseminated intravascular coagulation. Okay, and if your bleeding time is prolonged, but your platelet count is normal, PT APT is normal, your counts are normal, but patient is bleeding. So think about a platelet dysfunction. It can be inherited like Glanzmann's or Bernard-Solier syndrome, or it might be drug-induced, like aspirin or clopidogrel or any other antiplatelet agents. Sometimes due to diet like excess fish oil or garlic also can hamper your platelet function. The penultimate one, if you have a prolonged bleeding time, a normal platelet count, a normal prothrombin time, and a prolonged APTT, then you think about a von Willebrand's disease. Prolonged APTT with a prolonged bleeding time is von Willebrand's disease. This is the most common inherited bleeding disorder in the world. And there are scenarios where all your lab tests might be normal, but still the patient might be bleeding, and there might be a bleeding disorder like factor 13 deficiency or an alpha 2 antiplasmin deficiency. Then you think about this scenario. This you might get in the lab. Patient might have recurrent IC bleeds or recurrent bleeds after any surgery or trauma, but all your lab parameters will be normal. So in that, you depend more on the history, and then you got to evaluate. You cannot ignore the history. So that is shortly about your basic physiology and PT, APT, bleeding time, and how do you approach when those values are abnormal. But despite your labs, you have to be very sure on the history. You have to be convinced that the patient is bleeding. And this is the common scenario we see in our clinical practice. That's why I thought I'll talk shortly about thrombocytopenia and its approach. Okay, so when do we say it's thrombocytopenia? When your platelet count is less than 1.5 lakhs. But remember, when the patient is having a platelet count of 1 to 1.5 lakhs, that's grade 1 thrombocytopenia. Over a period of time, like 6 months, can be normal for them. Okay, so trials have shown that when the patient is followed up and the platelet is not dropping, that maybe is normal value. So clinically, less than 1 lakh, we take it as significant, but theoretically, we say less than 1.5 as a thrombocytopenia. You can classify them as per the values into mild 1 to 1.5 lakhs, moderate is 0.5 to 1 lakh, and severe is when it is less than 0.5 lakhs per microliter of blood. And you just not chase the numbers, you see whether the patient is bleeding or not. And this simple chart tells you about the of thrombocytopenia and the bleeding migration. So generally, the patients don't bleed at all when the platelet count is 50,000 or above. Okay, even a major surgery other than neuro or a retinal surgery can be done when the platelet count is more than 50,000. There are special scenarios where they shouldn't be. Otherwise, more than 50,000, the hemostatic challenge is usually well taken up by the body. Okay, but less than 50,000, what happens? When there's a trivial trauma, there might be a prolonged bleed. Okay, less than 30,000 is not safe, and even when the platelet count goes to less than 10,000, there is a high chance of spontaneous bleeds. So less than 30,000 is the arbitrary cutoff. We take a safe platelet zone. Less than that, patient has a high chance of bleeding. Less than 10,000, despite any stimulus or trauma, patient might bleed spontaneously. So that is just to infer from this chart. You remember two important values: 30 is safe, less than 10 is there is high chance of spontaneous bleeds, and more than 50, usually patient doesn't bleed. Okay, so major concerns, as I told you, less than 50,000, should, if the patient is not bleeding when doing a pre-anesthetic checkup, see the surgical bleeding is possible when the count is less than 50,000. Just history may not be enough. You have to see what is the count also. And spontaneous less than 10,000 has already been discussed. And generally, ITP being a very common disorder, we overestimate the patient might bleed a lot, but we'll come to that later on the slides. And there are scenarios where patient might have thrombosis despite thrombocytopenia. So that's like a paradox. What are those scenarios you should remember? One is heparin-induced thrombocytopenia, which occurs commonly from 5th to 14th day after starting heparin. So once you start heparin, maybe 4th or 5th day, you should follow up for the platelet count, whether there is hit or not. Hit occurs in the time with the patient might have, but the patient might have a thrombosis. The other next one being an antiphospholipid antibody syndrome. That's also an immune-mediated pathology where patient might have predominant immunological problems, or it might be thrombotic also. Again, a patient might have thrombocytopenia and thrombosis there. Then DIC, as everybody, all of you know, that DIC has bleeding and thrombosis happening at the microvascular level due to endothelial injury, and you can have thrombocytopenia and thrombosis. And thrombotic microangiopathy like TTP, HUS, they can have thrombosis and thrombocytopenia. Last being paroxysmal nocturnal hematuria, because that's acquired genetic disorder which has an overlap with aplastic anemia and myelodysplastic syndromes. They all belong to one family as like bone marrow failure syndromes. So still they can have a thrombocytopenia and thrombosis. So these are the common clinical scenarios you should think about. So moving on shortly about blast, they mature and become a megakaryocyte. A megakaryocyte is the largest cell in the bone marrow. Okay, that can be seen on just the scanner view. 4x magnification, you can see them easily whether they are there or not. And platelets are formed by shedding of the cytoplasm of the megakaryocytes. So they just bunch off and they are thrown into the circulation after separating from the parent megakaryoblast. And each platelet, each megakaryocyte will give you around 8,000 to 10,000 platelets. Okay, so now once they are formed, how they are removed? They have a regulatory mechanism. The hepatic Asheville-Morel receptors can, once these platelets are old, they are decylated and they are removed. So the megakaryocyte forms it by budding. They have a receptors over them, and when they age, they decylate, and the liver receptors they recognize that and they remove it. Once they are removed, we know in the liver secretes thrombopoietin. So when there's an rapid removal, when there is an accelerated removal, liver gives a signal through thrombopoietin, which stimulates the megakaryocyte to form more platelets. So this is how the cycle goes. So thrombocytopenia can occur basic mechanisms. They are very simple. First is a bone marrow pathology. So when there is a bone marrow abnormality like a stem cell disorder or an infiltration in the marrow, when the marrow is at fault, they may not produce enough platelets. And as I already told, each megakaryocyte can produce approximately 5,000 platelets, and there is a steady rate at which it is produced. Whenever there is a sequestration or increased loss, as in any other ITP, there is a RAMO, the production also goes up to compensate for the loss. And bone marrow disorders, you think when there is a platelet production is hampered, are nutritional deficiencies like B12 deficiency, folic acid deficiency, a myelodysplastic syndrome, where it may is a stem cell disorder. You don't have a quality cell being produced, so they get distracted within the marrow itself. It could be an infection and sepsis related. Production might be hampered as well as sequestration might be. So this is the first mechanism. The next mechanism is an increased platelet destruction. So marrow is normal, but it happens more in the peripheral circulation. That is the reticuloendothelial system, in the spleen or liver or the other macrophage systems. Okay, so here for the whatever loss is there, marrow produces more platelets, so you'll have an increased immature platelet fraction circulating in your blood. So the destruction is the second mechanism. The third, these mechanisms are less common. One is dilution, especially when a patient is taken up for a major surgery, when they come after a massive or in a there's significant RTA requiring massive procedures or fluid resuscitation, or due to our dilutions, there might be an increased plasma volume and reduction in the platelet count. The last is redistribution of splenomegaly can have a large pooled platelets there, so it may not be accountable on the when you do them. So they will be just pooled there, locked up there. They will not be participating more in the circulation. This can be due to redistribution of splenomegaly, as in like cirrhosis with portal hypertension. They might get just pulled up in the spleen, or sometimes as in myelofibrosis, even if they are formed well in the marrow, they may just get pulled up in the spleen. So those are the four mechanisms what you should remember: in less production, increased distraction due to dilution, and they might be pooled. Depends on the clinical setting, like how the patient is. An OP patient, when they are just referred for thrombocytopenia without much bleed, it may be simple ITP or infection related. On the other hand, when you have an inpatient, the chances of thrombocytopenia being multifactorial is very high. It might be just due to infection, hospital acquired, due to antibiotics, many other drugs might also cause repeated sampling, or many things might be cause for your fluid resuscitation, all might add up being multifactorial. And pregnancy is a special scenario where there is a risk to mother and fetus. That is also an important thing. There are special guidelines for that, you should remember. And the one is the patient setting. The next one is the presence of bleeding, whether the patient is bleeding or not. So depending on that, you'll have to manage the patient. And there are special scenarios like intracranial bleed or other things. And for thrombocytopenia, bare minimum history you need is what is if possible, you have to go through the documents or the file of the patient to know what is his prior platelet count, whether there is a chronic thrombocytopenia or whether it's all acute. The chronic usually doesn't cause much problems. Patient may not bleed, may be just there for a long time unnoticed, like a low risk myelodysplastic syndrome. Acute is always dangerous. A sudden crash in platelet count is like an ITP is more dangerous. A patient may bleed into the visceral organs or critical organs. Family history is important to think about inherited thrombocytopenias. Prior bleeding is also will also tell you about whether the high risk patient or not. What a significant drug intake should be looked into. You should go through all the prescriptions when they come to you, and hence any heparin being given or not, any infectious exposures, travel history, and diet also sometimes, because a bleeding patient might have platelet dysfunction due to sometimes like excess fish oil or garlic might reduce them. And examination, any hematological system, skin and other sites, you see for bleeding sites, organomegaly and nodes, gum bleeding or gum hyperplasia might give you a clue like AML, and bone tenderness as in leukemia. And few on the laboratory side, what are you will concentrate? You think more about platelet clumping whenever the count is low and the patient is not bleeding or never had any bleeding in the past. The first and the foremost thing to be ruled out is pseudothrombocytopenia. This is a lab phenomena. It does not happen in the body. When the sample is taken in an EDTA vacutainer, EDTA strongly chelates the calcium and platelets clump together. So this is an in vitro phenomena. It does not happen in the body. So when the platelet clump is formed, the poolter will think the chunk as one platelet, and the overall count might be low. And this can be overcome by when you see the citrated sample, you will get a relatively accurate platelet count. But remember, when you see a citrated sample, you consider only the platelet count. Don't take the white cell or the red cell, what is reported on a citrated platelet count or citrated sample, because that is not appropriate for them. Only for platelet, you can consider citrated sample, and never estimate a hemoglobin or white cell total or differential counts on the citrated sample. Obviously, smear will give you giant platelets is another important thing we should look for, because giant platelets, or even the poolter has a specific value from a lower limit to an upper limit. What has been assigned to count as platelets will be included in the platelet count. If they are larger than the upper limit, they won't be counted. So you might have a low count, but the smear might have a larger platelet. This happens commonly in people from Bihar or West Bengal, where they will have a constitutional macrothrombocytopenia. The platelet formation itself they'll have large platelets, so that will not be counted in the Coulter. But when you look into the smear, platelets will be normal, but they'll be large. So this is constitutional macrothrombocytopenia. Patient may not bleed, and whenever there is any destruction like ITP, there also you can have giant platelets. But when you have a large number of giant platelets, you think about constitutional macrothrombocytopenia. And red cell fragments, why that occurs? As I explained, if they are large, they'll move into the red cell column on the Coulter. So they will not be counted as platelet. And whenever there is thrombocytopenia, what you look in the RBCs, these are the features you have to look for, which might give you a clue why the thrombocytopenia is there. The patient is having thrombocytopenia. After you see a smear, if the patient has schistocytes and fragmented cells, it can be microangiopathic hemolytic anemia. If they have microspherocytes, it can be event syndrome like immune-mediated platelet and red cell destruction. And NRBCs might give you clue something is infiltrating the marrow, and the earlier red cells are thrown out rapidly. And parasites might give you clue like malaria might be a etiology for your thrombocytopenia. So the pictures, we have this is the helmet cell, you have schistocytes, microspherocyte, all the important things you should look for. And nucleated red cell might give you clues about what the diagnosis what patient you're dealing with. In the WBC, similarly, when in a case of thrombocytopenia, you can have certain features like leukemic blasts might be there, which will explain your thrombocytopenia. You can have pseudopellular cells, which will happen and which can be seen in myelodysplastic syndrome, or an inherited platelet abnormality like MOH9 related syndromes. This is very rare. You can have a large platelet, a less platelet count, and an inclusion body in the white cell. We think about certain syndromes like Epstein, Fechner, Sebastian syndromes, and all. They all are family. They all are a family called MOH9 related disorders. So, but finally, your communication between you and the pathologist is of paramount importance, because whatever is all your differential diagnoses have to be listed, so that the pathologist will be sure what he'll be clear to see for the findings what you need to see as per your clinical diagnosis. A simple flow chart summarizing all. So first, when you have a thrombocytopenia on the laboratory side, you see a peripheral smear. Rule out pseudothrombocytopenia due to platelet clumping. If that platelet clumping is there, then you need not evaluate him further at all. If there is true thrombocytopenia, you see for the associated features what we discussed in red cells and white cells. If there are schistocytes, you think about thrombotic microangiopathy like TTP or HUS. It can also occur in DIC, and these are the further tests you need to do to either rule in or rule out them. And if there are blasts or nucleated red cells, you think about marrow pathology, could be leukemia or pseudopellular as in myelodysplastic syndromes, dactylocytes, and myelofibrosis. They are the findings which you need to look for. If you have microspherocytes, RBC clumping, or agglutination, think about some immune-mediated hemolysis, and immune-mediated thrombocytopenia can be a feature as in event syndrome. And you need to do those tests to confirm them. And when you have lymphocytosis or atypical lymphocytes, you think about a chronic lymphoproliferative disorder. If you have neutrophilia, toxic granulation, think about infections. And when you have a giant platelets with WBC inclusion, this scenario is very rare. Then you think about MYH9 related abnormalities. And any isolated thrombocytopenia, you have to rule out the viral transfusion transmitted viruses, HIV, HPV, HCV are not there. And also H. pylori is also an important cause, which can be a cause for your thrombocytopenia, and appropriate investigations are needed. So this slide tells you how important your peripheral smear examination is. If that is ignored, a lot of information can be missed. So now moving on to the common situations encountered when you have handled thrombocytopenia. There are ITP infections and pregnancy. Okay, so immune thrombocytopenia. This is idiopathic thrombocytopenia. It's immune-mediated destruction. So one's own immune system identifies the self platelets as abnormal and destructs them. So when you have an immune-mediated thrombocytopenia, you think about secondary causes, because the larger diagnosis might be missed. Like APLA, common variable immunodeficiency, is one important thing which has to be ruled out in a pediatric population when they present with ITP, especially when the child has recurrent skin infections or ENT or respiratory tract infections. You think about common variable deficiency. You have to take samples for your immunoglobulin levels, and if needed, you have to do a lymphocyte subset also to rule out CVID. Because CVID also responds to steroids, you might misdiagnose just by starting steroids. So you evaluate before starting. APLA, I have already described. Lymphoma, CLL, due to the infiltration in the marrow, you might have thrombocytopenia, and so that might be an important mechanism. Still, in CLL and angioimmunoblastic T-cell lymphomas, there are certain lymphomas where there will be peripheral destruction of platelets also due to a mediated mechanism. And HIV, HCV infections can also behave like ITP. And simple classification of ITP, if less than 3 months, you call them as newly diagnosed ITP, or newly diagnosed. 3 to 12 months, you call them as persistent ITP, and chronic is more than 12 months. Refractory is you call only after splenectomy. Despite splenectomy, if there is no improvement in platelet count, then you call it as refractory relapse ATP. Okay. Now, examination. Usually in ITP, though classically we say splenomegaly is a feature, and clinically we never palpate spleen. There's a splenomegaly, just like aplastic anemia. We think about an alternate cause for ITP. Usually in ITP, spleen is not palpable. Radiologically, it might be marginally enlarged. Mucocutaneous bleeding is the characteristic symptom of ITP, and it could be a surrogate marker for your visceral organ or CNS bleed, like intracranial or a GI bleed. Then that is an emergency whenever you see wet purpura in the mouth. And bone marrow in an ITP is done to rule out other abnormalities. Usually it is normal. The cellularity for age is normal, and your megakaryocytes are increased. So whatever platelets have been lost in the peripheral blood, the peak ITP only if platelet is less than 30,000, especially in chronic. In acute, even if less than 50,000, if there is bleeding, you got to acute will require treatment mostly, especially when the platelet is less than 50,000. In chronic ATPs, if it's less than 30,000, then you need to treat. More than 30, if the patient is not bleeding, possibly you can very well watch. Basic lab evaluation, you need a simple CPC reticulocyte count, peripheral smear examination, immunoglobulin levels, especially to rule out CVID in pediatrics, and bone marrow examination. Though it's not an important examination as per the international guidelines, to say that they don't say that marrow is mandatory, but in our setup where the pathologist might miss or the history is not given properly to the pathologist, it's always better before starting. It's better to document that marrow is normal. Donor blood group, then direct antiglobulin tests, Helicobacter pylori, HIV, HCV are the viral infections you should rule out in and before managing ITP. And 3 FDA agents are there as first line: IVIG, steroids, and RH and TD immunoglobulin. So if there is a simple flow chart, if there's life-threatening bleeding, you choose IVIG and pulse steroids after that. If there's a contraindication to steroids as an active infection or uncontrolled diabetes mellitus, then preferably you go for IV. Pediatric patients, it's better to go for IVIG because as per the weight, maybe 1 or 2 bottles for them. In adults, it may not be always possible because 60, 70 grams, which might cost a lot. So in a newly diagnosed ITP, if you start steroids based on your finances, then you give for 4 to 6 weeks, not more than that. After 4 to 6 weeks, you should taper and stop steroids. If you shouldn't give for a longer time, then you might land up with complications like hydrogenic problems, Cushing syndrome, the BP might be high, sugars might be high, there might be osteoporosis, sleep and appetite might be disturbed, patient may put on weight, facial puffiness. A lot of complaints will be there whenever you start on 1 mg per kg per steroids. So whenever feasible, you go for IVIG in acute ITP. Now setup is not always possible, so steroids, but you counsel the patient upfront that there will be some weight gain. You have to monitor for sugars and hypertension. If response is good, then maybe after 4 weeks you can take rapid taper in a week or 2. So by 6 weeks you should stop steroids. If there is the response is not there adequately, then you choose a second line agent. But there is no head-to-head comparison with second line agent is good. There are multiple options. You can give mycophenolate, azathioprine, rituximab, or the newer thrombopoietic mimetic agents. And in India, we use dapsone also, which is very cheap, which can increase your platelet count, but it will take time. All the second line agents don't work immediately; they'll take time. So this flowchart shows you the multiple second line agents there available, but it's very difficult to say which is good. Or most of them have a two-third response. That is, out of 100 patients, 60 to 70 will respond, but 30 to 40 might drop. Poor man's treatment would be still splenectomy for a chronic ITP, because he need not come back again and again to the hospitals to monitor for immunosuppression based on his counts. The cost might be one. This is one shot. It can be done freely also in certain centers. So that will, if you feel the patient may not follow up properly, then this would be the choice. But only thing, make sure that he's on antibiotic prophylaxis after splenectomy. That counseling has to be done, and he should get his pneumovac once in 5 years later. How does IVIG act? It is just by inhibiting the Fc gamma receptor mediated uptake in the macrophages. So when the platelets are coated by autoantibodies, the macrophage recognizes them by this Fc gamma receptor. So this recognition and intake of platelet into the macrophage is inhibited by IVIG. So that is the mechanism. You can give 1 gram per kg, 1 to 2 doses. And the anti-immunoglobulin, how does it work? It is given as 50 to 75 grams per kg. Here, you're going to sacrifice the red cell to salvage the platelets. So the patient has to have a Rh positive blood group for this drug to work. So when you give an Rh positive patient anti-D immunoglobulins will go and bind on the red cells. Now, since antigen antibody reaction has happened, there will be complement fixation, and macrophages in the spleen and liver will destruct them. So the spleen and liver will be busy in chewing the red cells which are coated with antibodies, and they'll leave the platelets aside. So that is how this drug works, but it's not commonly used in our setup. And the new kid in the block is TPO mimetic, that is thrombopoietin mimetic. And as I have shown you in the first slide, platelets are egressed as they bunched out of the cytoplasm, and they're pushed and thrown out into the circulation from the megakaryocyte. So what happens when a thrombopoietic agent is given? It stimulates the megakaryocyte to produce more platelets, and they're pushed into the circulation. So there are two drugs. One is romiplostim, the other is eltrombopag. They work at different receptors, and they mediated through JAK2 pathways and increase the platelet count. So this chart summarizes you all the agents for ITP, starting from corticosteroids, IVIG, and rarely danazole, Vinca alkaloids. Even chemotherapeutic agents have been tried, which blocks the macrophage uptake there. And this entire process which happens in spleen can be removed by splenectomy. The other agents, what we have described, is T cell mediated and B cell mediated, where the antibody production from the B cell can be cut down by giving rituximab, and T cell is needed for your B cells to produce antibodies, so that can be knocked off by azathioprine, cyclophosphamide, cyclosporin, corticosteroids, and danazole. So, and thrombopoietin agents and your androgens might increase your platelet count also. So multiple agents at different by acting by different mechanisms can help you to sort out your ITP. That is shortly about ITP. Infection-related thrombocytopenia. It might be a simple OPD basis management, like in malaria, or sometimes it might be a devastating meningococcemia, some other infections happening in your ICU. So broad principles: virus-associated thrombocytopenia, and the virus can bind to multiple platelet receptors, a enormous number of receptors. Different viruses can have a different target over the platelet receptors, and appropriately can cause reduction in your platelet count. So again, the same mechanisms. It can reduce production by injuring the marrow, as in dengue, and it can increase your destruction in the periphery. It can elicit response, immunological response, and the macrophages might remove more. It can cause apoptosis of the megakaryocyte, and it can interfere with the thrombopoietin production in the liver also. Multiple theories have been put forth, and many mechanisms. Once the immune system overcomes the viral insult, gradually the platelets will recover. HIV is a special scenario where you see thrombocytopenia. It ranges from 5 to 25%, especially in the early part of the HIV. The patient will behave more like ITP. They'll have increased destruction, but when your viral load goes high, it will behave more like an infection causing direct myelosuppression in the marrow, and the receptors involved are CXCR4 on the macrophages. Dengue is very common scenario, which most of you know. It's a commonest infection in the tropic, and you can have just an asymptomatic patient to almost a patient with dengue hemorrhagic fever culminating in death. A multifactorial cause, same myelosuppression, increased sequestration, vascular leak, increased dilutional due to fluid resuscitation, all can happen, and even DIC could be a contributing factor in dengue. And in thrombocytopenia and dengue is transient, and we know this maybe from fourth, fifth day it will start dropping. They'll reach an adult by day 8, 9, and then they'll gradually recover in the next few days. And we have a correlation in acute leukemia. Whenever there is a leukemia, less than 10,000, the chance of beat is high, and more than 30,000, the beat is not so high. Then we don't see that correlation much in dengue. Multifactorial role might be contributing there. And remember, platelet transfusion, they are very dangerous, especially when they are not indicated. Less than 10,000 in dengue, yes, we can give to prevent spontaneous bleeds. But you have to remember that platelets are the agents which can cause the maximum chances of infection on comparison to your packed cells or FFPY. Platelets are stored at room temperature. They are not frozen, they are not kept in cold. If you keep the platelets in cold, they'll get activated, they'll degranulated, and they won't be useful. Okay, so they are stored at room temperature in a shaker. They should not be stationary. They have to be kept at a constant motion. So the shaker keeps on agitating the platelets gently so that they don't settle at all. So that is how the platelets, and since they are not kept in cold, the chance of microbial growth is very high. So that is the reason you get a higher chance of fever, sepsis with platelet transfusion. So you have to really decide whether there's a strong indication to keep platelets or not. You can't just transfuse when even just based on your counts. And this part I'll discuss about your thrombocytopenia in pregnancy. So generally we know as the patient, as the individual goes from first trimester to when she progresses towards delivery, there is a drop in platelet count, especially in the second and third trimester. Okay, and there is no relation there to pregnancy. There is some there are causes for pregnancy, specific causes as preeclampsia, HELP syndrome, AFLP. They are all thrombocytopenia with systemic disorders. Isolated can happen in gestational thrombocytopenia. That is the most common cause of thrombocytopenia in pregnancy. The others being less common. Next, after GTP, it is followed by your PIH, HELP syndromes, less likely for ITP to be a cause. In gestational thrombocytopenia, you have to know about this because you might get consultations from OBG regularly. So this happens in your second or third trimester. If there is thrombocytopenia in your first trimester, it is not GTP. You have to remember that. And usually it is mild. It varies from 50,000 to 1 lakh. And there is no risk of bleeding at all. And other blood count series, white cells and red cells are usually fine. They are not affected by this thrombocytopenia. And there is no thrombocytopenia to the offspring. Whereas if you compare with ITP, it can occur at any time in comparison to your second and third trimester occurrence of gestational thrombocytopenia, and platelet count can drop even less than 50,000. Okay? And after delivery, still it can persist. Okay? Whereas gestational thrombocytopenia just recovers. Neonatal thrombocytopenia is a possible phenomena in your ITP. You have to check the neonate's platelet count after delivery in ITP. And postpartum resolution is always the rule in gestational thrombocytopenia, but it may not happen in your immune thrombocytopenia. So when will you treat an abnormal platelet count in pregnancy? If there is no more than 30,000, if there is no bleed, you can very well wait and watch to see what is happening. If immediate delivery, then you can consider a low dose steroid. Okay. And we know as per BCSH guidance, even 20,000 is enough for a safe vaginal confinement. More than 50,000, is needed for LSCS, and any epidural, you need at least 80,000. So first line agents, again the same rule. We have IVIG steroids. RH immunoglobulin usually is not given. So only two options we have in pregnancy. And second line, a lot of agents are there. You can't give the chemotherapeutic agents in pregnancy. So possibilities left are anti-azathioprine, cyclosporin, and dapsone, which are, but they also take time. They don't work immediately, unlike steroids and IVIG. Those are the only two agents which work very fast, and obviously splenectomy is the fastest. All the other agents will take few weeks for them to show response. You can't start azathioprine and expect a result immediately. It will take at least 4 to 6 weeks for them to show a response. And delivery, it's mainly based on your obstetric indication. There is no, but you have to take certain precautions to avoid procedures which can increase the risk of bleed, like forceps vacuum extraction, fetal scalp electrode sampling, and all. So that is all to be discouraged. Anesthesia, spinal, if it's more than 80,000, not a problem. Less than 80, it's better to take under GA. And epidural is also more than 80,000. If it's low, we can consider short-term steroids or IVIG as what we have discussed earlier. Risk to the neonate in gestational thrombocytopenia, there is no risk. If there is an ITP, there is a risk. Less than 50,000, if the mother has a platelet count of less than 50,000, the newborns have a 10% chance of developing a low platelet, having a low platelet count. Less than 20,000 in 5% cases, and ICH is possible in up to 1%. If 100 deliveries, one might have an intracranial hemorrhage. So that's why you have to see the neonatal platelet count. And if the neonate has a low platelet count, less than 50,000, it's always better to give a dose of IVIG. And the best predictor to say that severe thrombocytopenia at birth is occurrence in the previous sibling. If there is a previous birth, you ask for the history, whether child required any hospitalization, admission into the NICU for thrombocytopenia. That may give you a clue that this child also might have a higher chance of low platelet count and bleeding. And I'll go through a few cases. This is a 63-year-old man with ischemic heart disease. He's planned for an elective procedure, CABG. During the pre-anesthetic workup, his platelet count is 44,000. So he has no bleeding at all. He uses aspirin, and previous platelet counts have been varying from 36,000 to 2.5 lakhs at different labs. So what next will you do? Obviously, when you have a low platelet count, next foremost thing is to, after examination, is to do a smear. In the smear, if you see this, so this will be just the thrombocytopenia. You need not worry at all. You can very well clear the patient for the procedure. Okay, he'll have normal platelet counts, but it's a lab phenomena which happens due to EDTA, which might clear off in citrated sample. Next, this is a young female, 38-year-old female with no comorbidities. She comes to the casualty with onset of severe headache since last 2 days. In examine, she has a low-grade temperature and she is lethargic. These are the labs you're getting. You have an anemia, 8.4 grams % of hemoglobin. The white cell count seems normal with a normal differential count, which I have not mentioned there, and severe thrombocytopenia. There is reticulocytosis. There is an elevated serum creatinine and a mild indirect fraction of bilirubin. Total bilirubin is 1.6, direct is only 0.4. And your LDH is, so when you have this picture, when you have an anemia, reticulocytosis, indirect bilirubinemia, and raised LDH, you think about hemolysis going on there. And when you have a high retic count, you presume that marrow is responding for the anemia. Whenever there is a blood loss or hemolysis, and if your retic count is high, probably there is no pathology in the marrow, because marrow is adequately responding for whatever need is happening in the periphery. And these are spiculated cells, what you see as schistocytes in the peripheral smear. So when you see them, this is an emergency. It happens in thrombotic microangiopathies like HUS, TTP, or DIC. So TTP is a pentad, so hardly you see the pentad, but you take the clinical scenario into consideration. When the patient has fever, neurologic or renal impairment, and the lab values are like this, what we have seen in this patient with anemia and evidence of hemolysis, then you think about this. This is an emergency, and preferably the patient has to be referred to a center where there is facility of plasmapheresis. Patient 26 36-year-old female, a newly diagnosed ITP. She is primary gravida. Her term platelet is only 15,000. We have to see what is the response with those agents. For middle-aged man, with if the patient, you see this patient, if he is a known case of ITP already and comes with a bleed, like catastrophic bleed, extradural hemorrhage, the CNS, platelet is only 15,000. Obviously, neurosurgeon uh, can't take immediately for surgery. Then an emergency splenectomy followed by immediate evacuation might help in this setting. So we have full patients like that who comes with the CNS bleed, but you have to be very sure that it is ITP, that is marrow is normal. Because if the marrow produces platelets, and they are restricted outside, then only your splenic removal will help. The marrow is at fault, then your splenic removal will not help. So this is possible in documented patients. If already known patient with ITP where your marrow has already been done and has been documented that marrow is normal, then this might help in managing the patient. And so to summarize, first line treatment for ITP is steroids, IVIG, and anti-immunoglobulin. We don't use this much. These are the two other agents. Pediatric, better to choose IVIG. Adults, if there are finances is not a problem, then I would still say IVIG would be a better choice. And for the steroids, second line agents, there is no head-to-head comparison to say which one is better. It's all by trial and error method. You give one agent, wait for maybe 3 to 4 months. After 3 to 4 months, if the one agent is not working, then you stop and switch over to next. And maybe 2 to 3 agents you can try, and then otherwise you have to counsel the patient for splenectomy and vaccinate properly. And chronic ATP, if the patient is having a platelet count of more than 30,000 for a long time, and if he's not bleeding, you might very well observe without switching over or pumping in steroids. So thank you all for your patient listening.
Yeah, Dr. Subbaiah, you can on your video. Yes, thank you, sir, for extensive review on bleeding disorders. You have almost covered minor complaints like fever and a headache until the extensive diagnosis with the bone pathology of blood smears. This is really made helpful in our clinical practice to diagnose, and entire things is focused on the platelets. So giving this COVID scenario, what means many consultations are telemedicines or teleconsultations. So what advice you will give to the participants, doctors, that how to look for on the when they receive the complaints on telemedicine?
Okay, so always better to examine the patient, but if that is not possible as in this pandemic, then you have to go by your old reports, see them properly. Then depending on your symptoms, you can take it from there. But ultimately, if you need a marrow, then obviously the patient has to be seen in person and then evaluated appropriately. COVID is one scenario where we see thrombocytosis also if there is intense inflammation or thrombocytopenia. Both ways the patient might present. It's very heterogeneous. We need more data to say which are those patients will have thrombocytopenia or thrombocytosis. That may take some more time to understand the natural history, what is exactly happening.
Yes, doctor. As we know that in the COVID management, antiplatelet agents are also prescribed a large. This is one of the important drug in protocol management. Plus, post-COVID complications are also coming up in a bigger way, whereas the myocarditis, cardiovascular complications, and blood-related complications are more. Are you coming across any such cases, those who are post-COVID recovered patients?
Yeah. In the post-COVID scenario, we see a lot of patients with thrombosis. We have seen mesenteric ischemia, cortical venous thrombosis, DVT, pulmonary embolism, and a lot of patients. So That's the way to go. We have to give anticoagulations if your platelet counts are fine and there is no significant bleeding for a few weeks at least until the patient is ambulant and the inflammation has settled down. So I would say yes, prophylactic anticoagulation has a strong role in giving for COVID patients, especially until the inflammation subsides.
Yeah. One of the important question has come here from the participant. Being a blood bank person, what advice you give to us to avoid unnecessary platelet transfusion, particularly in pregnancy?
So that's a challenging scenario. It's very difficult to convince the clinician there. Finally, it's a call of the clinician. Maybe and when they manage as a team, the physician or the hematologist there with the obstetrician might be the teamwork might uh, help in sorting out that. Otherwise, the chances of unnecessary transfusion is always high in our setup. But definitely, if the platelet count is more than 50,000, there is no need for transfusion at all. Even in our practice, more than 20,000, if the patient is not bleeding, we don't transfuse. Less than 10,000, we give platelets, provided there is no destruction. For example, in an ITP, even at 5,000 platelet count, we don't transfuse at all. We do bone marrow procedures, we don't transfuse platelets because even if you transfuse there, it's going to be destructive. Because the marrow is not at fault, the synthesis is happening well, but they're just getting distracted outside. So you should not go by the platelet count there. If your marrow is not producing as in leukemias or infections, then like dengue, then yes, you have to transfuse. But I would say less than 10,000, we should give transfusions, even if the patient is not bleeding, provided your marrow is not producing platelets. 10 to 20,000, if the patient has an increased consumption like fever, then you can give. Less than 50,000, if there is bleeding, obviously you'll have to give. You can't take chances there. But more than 50,000, if the patient is asymptomatic, there is no need for any transfusion. 20 to 50,000, there is no hemostatic challenge. The patient is not undergoing surgery or any invasive procedure. It need not be transfused at all. So that if it's going to be a normal vaginal delivery, more than 20,000, you might just give steroids and then you can manage. If it's LSCS, then obviously 50,000 is needed. So you might give some platelet transfusion before taking in the patient for the procedure. And there are scenarios where even ITP patient people give platelets, especially to cover peri-procedural time. Knowing that whatever has been transfused will survive there for some time before they're getting distracted by the time procedure can be done. But I don't think it will help much. It's a tough scenario to say where to transfuse and where not to transfuse. It's going to be the clinician and the team of physician and hematologist have to decide whether to transfuse or not. Guidelines are there, but let's say practices has to be individualized.
Yeah, thank you, doctor, for this. One more question has come from Dr. Anil. He's asking that what should be advised to female patients of aplastic anemia during pregnancy? You have covered in a brief during the pregnancy is one of the important factors. So frequent it is during pregnancy have the low platelet count. And this question is particularly, so what is the advice for female patients of aplastic anemia?
Okay, so aplastic anemia, just like your ITP, where you have seen the degree of thrombocytopenia, similarly in aplastic anemia also you have a degree. It could be a non-severe aplastic anemia, where the platelet count is fine, will be more than 20,000, and your absolute neutrophil count will be more than 500, or it might be severe thrombocytopenia, severe aplastic anemia, where you have a low neutrophil count of less than 500 or very severe less than 200. It all depends. If it's a non-severe aplastic anemia, you can just manage like any other pregnancy. Nothing much is needed. But if it's a severe aplastic anemia, then the chance of bleed and losing the pregnancy is high. But there also, we don't give prophylactic transfusions. In aplastic anemia, platelet transfusions are given only, even though the marrow is not producing, we give when there is a bleed. Reasons being, platelet survival is there. Platelet hardly lives for maybe 4 to 7 days in the circulation, but with the time you apheres from a donor, you screen for all the viruses, then you transfuse. Already 1 or 2 days have gone there, and it'll help the recipient for another 3 or 4 days. But the more and more you transfuse, the patient will get aluminized. Initially, the platelet might survive for maybe 4 or 5 days. Later, as the transfusion number increases, it may not survive that much time. It might get distracted rapidly more earlier. So we don't gain anything from that. So whereas we expose the patient to a higher chance of reaction, allergic reactions, anaphylaxis, higher chance of sepsis, and we are going to eliminate. And especially if after delivery the patient is going to undergo a bone marrow transplant, then the lesser transfusion will help better graft uptake and graft survival there. So less transfusion do well than highly transfused patients. So just like a renal transplant there also. Here also we try to transfuse them less and eliminate them less. So if there is no bleed, we would not, even if the platelet count is 2000 or 1000, we don't transfuse neoplastic anemia unless there is a bleed. Same thing I would say it applies to pregnancy, but when the patient is delivering, then there you have to transfuse. Otherwise, if the patient is asymptomatic, it's you have to explain the risk to the patient, and it's very difficult to transfuse them throughout their pregnancy. So if you're planning any procedure or when the patient is about to deliver, then you can transfuse. Otherwise, I don't think you should transfuse even in aplastic anemia if the platelets are low and the patient is not bleeding.
Yes, doctor. The question uh, for about I would like to thank you for very nice and elaborative presentation where you have shown the pictures and the clinical management as well. We hope that this will be very useful. And looking at the telemedicine, more number of patients still not visiting and phone consultation during this COVID pandemic and coming few months, we need to be very careful. We want to continue such a kind of meetings on the webinar platform for our doctors across the country. And we look forward for your continuous association with Panacea Biotech. I request our business unit head of oncology department, Dr. Shailendra Srivastava, to give vote of thanks. Shailendra ji,
Thank you so much, Dr. Kunal. Indeed, pleasure going through with the complete program. And it has been a wonderful presentation by Dr. Subbaiah and a very, very basic, and from basic to basically the major complications in hematology. A complete coverage, and I hope that audience definitely would have enjoyed the entire session. On behalf of Panacea Biotech, we thank you, Dr. Subbaiah, and we wish to have many such programs for the betterment of medical fraternity. Thank you so much, sir, and thank you so much for having you here on this program. Thank you so much,
Thank
Dr.
you.
Kunal.
Thank you, sir. I would like to thank Panacea Biotech team for providing me the platform to discuss this common topic, which is very important for our colleagues in our clinical practice. Thank you.
Thank you, sir.
Thank you so much, sir.